Hello learners, welcome back. Today we are going to discuss from block 3, unit 3, health and nutrition of the tribals. And in today's session, we will be discussing on diet and nutritional status of the tribal. We all know health is an important aspect of development and nutrition plays a central role in determination of health and well-being of individuals and affects growth and development throughout the life cycle. Nutritional status of the tribal depends on the consumption of food in relation to the needs that influences the ecosystem in which they live. The health problems of the tribals are profoundly influenced by interplay of socio-cultural and economic factors which are quite distressing. So, it is necessary to understand the food habits of the tribals in view of their subsistence economy, social isolation and food insecurity. Their natural habitat renders them vulnerable to a host of astringent unsanitary living conditions, widespread poverty, illiteracy, ignorance, absence of safe drinking water, lack of personal hygiene and health education, poor utilization of maternal health and nutrition of the tribals and child health services, and also due to ineffective coverage of health services. A considerable proportion suffers from malnutrition such as protein energy and deficiencies of iron, vitamin A and iodine. And also many factors like their common superstition beliefs, customs, practice and taboos connected with health and disease intimately related to treatment of diseases that affect the morbidity and mortality of the tribals. And also when we look at their maternal and child care, this is also largely neglected, which is reflected in terms of high infant mortality and maternal mortality rates. Many diseases like malaria, meningitis, unspecified fevers, diarrhea, respiratory infections and neonatal tetanus takes a heavy toll. A large number suffers from various communicable diseases like leprosy, tuberculosis and venereal disease transmitted through contact with non-tribals. And also due to other infections like worm infestations are high due to semi-starvation, inferior food and unhygienic food habits, which in turn also affects nutritional status. Again, there is also acute food insecurity feature is commonly characterized with malnourishment, vulnerability and poor socioeconomic condition. It is reported that more than half of the tribal population is not consuming the recommended requirement. If you look at their diets, they are grossly deficient in animal protein, fats and vital nutrients like calcium, iron, riboflavin and vitamin A. Besides, there is also scarcity of food. They have superstitions and misconceptions regarding food in spite of all sufferings and starvations. Further, extremes of magico-religious beliefs and taboos, this also tend to aggravate the nutritional problems of the tribals. And there is also a high prevalence of malnutrition is reported in primitive tribal groups such as Langia, Saura, Kutia, Kont and Podi Buyan. The protein, energy malnutrition and iron and vitamin deficiencies are widely prevalent among preschool children. There is also a high rate of micronutrient deficiency is documented for adolescent girls, pregnant women and lactating mothers. So, owing to hard work along with the poor quality of food, females suffer from different ailments since their early age and survival tasks which result in inevitable neglect and adverse effect on the health during infancy. Now, when we look at the measure of nutrition status, this has been defined as a pathological state resulting from relative or absolute deficiency or excess of one or more essential nutrients, this state being clinically manifested or detected only by biochemical, anthropometric or physiological tests. The clinical examination of individuals is an important practical method of assessing the nutritional status of an individual and a community. The method is based on examination for changes believed to be related to inadequate nutrition that can be seen or felt in superficial epithelial tissues, especially the skin, eyes, hair and buccal mucosa, or in organs near the surface of the body such as the parotids and the thyroid glands. Occasionally, this may be supplemented in the field by certain physical tests with or without instrumental aids such as the testing of the ankle jerk. This method has the advantage as it is relatively inexpensive, neither elaborate field equipment nor a costly laboratory is required. Though the method is simple, but it has own limitations. Now, when we look at the age and body weight, these largely determine the nutrient requirements of an individual. The body weight and heights of children reflect their status of health and growth rate, while adult weight and height represent what can be attained by an individual with normal growth. Height, unlike weight, once gained cannot be lost as weight is not affected by chronic malnutrition. The nutritional goal of any country would be to provide adequate nutrition and health support to its population so that they attain their full genetic potential in growth and development. The measurement, which is called anthropometric measurement, that is done for Indian children up to 14 years belonging to well-to-do groups, have shown that they grow at rates similar to those of children in the developed countries. Malnutrition in children in the tropics is important not only because it is common, but also because it highlights important relationships between infection, immunity and nutrition which are of universal application. All malnourished children show reduced growth and muscle protein deficiency. Two polar types of protein energy malnutrition are recognized. They are marasmus and Kwashiorkor, but many children have a mixed clinical picture. Marasmus occurs in infant aged under 1 year when maternal milk supply is interrupted by death or illness, and in older children in time of famine. The child has clearly lost muscle and subcutaneous fat. The skin is dry and wrinkled and there is no peripheral edema. The hair is thin and dry. The body temperature is low. The child looks anxious but moves less than normal and may be hungry but vomit any foods offered. Such children are susceptible to diarrheal and respiratory infections, trachoma and vitamin A deficiency. Children with Kwashiorkor are usually aged 18 months to 4 years and have been weaned from the mother's breast. Muscle loss occurs but subcutaneous fat is preserved and there is obvious peripheral edema. The hair is dry, straight and depigmented. The skin is scaly and glistening, peeling and hyperpigmented. Especially on the legs, the abdomen is distended and the liver is enlarged. The child is fractious and irritable and often has diarrhea. The clinical vitamin A deficiency may be present. Children with mixed marasmic Kwashiorkor have a varied picture with muscle loss, edema and damaged skin. The diagnosis of the malnutrition syndrome is primarily clinical. Anthropometric documentation is essential for the individual child and for the study of the community. The body weight on a centile chart is a measure of current nutritional status, allowing for the presence of edema. Body length or height indicates previous progress in growth. Children with Kwashiorkor have low serum albumin, potassium, zinc, magnesium and calcium levels and low blood sugar and may be anemic with defective blood clotting. The treatment of marasmus requires the provision of adequate nutrients appropriate to the age of the child with powder or cow's milk as the basis, involving the mother if possible at all stages. The management of Kwashiorkor is more complicated. Clinical dehydration at present should be treated with oral rehydration solution. Adequate intake of protein and calories require frequent feeds of a mixture of skimmed milk, vegetable oil and sugar, sucrose or glucose, followed by cereals, pulses, rice, eggs and meat or fish according to the availability. The supplement of potassium and magnesium and vitamin A are also important for early treatment and should be followed with additional iron, folic acid and B vitamins. Children with Kwashiorkor may also have tuberculosis and malaria may also complicate convalescence. Now let us look at the prevention of childhood malnutrition in a community. This depends on adequate community food supplies, education of mothers in the use of nutritious foods which are cheap and available in their community, primary healthcare programs including monitoring of child development, treatment of or immunization against common infections, provision of vitamin A supplements. In India, prevention of childhood malnutrition is not possible at the present situation because of the extremely inadequate infrastructure facilities for healthcare in rural India, where the people are poor and there are no adequate food supplies in interior villages. Parents are illiterate, primary health centers are almost non-existent in the village. If we look at the percentage of institutional delivery in respect of scheduled tribes, this has increased from 17.7% to in the year 2005 to 6 to 68% in 2015-16, whereas for all categories the figure shows improvement from 38.7% to 78.9%. Also for ST women, deliveries attended by skilled health personnel have increased significantly from 25.4% to 71.5% during the period 2005-6 to 15-16. In both cases, there is a gap of about 10 percentage points for ST women as compared to overall women. As per the figures pertaining to the rural health infrastructure in tribal areas published by Ministry of Health and Family Welfare, there are 28,682 sub-centers, 4,211 primary health centers and 1,022 community health centers in position as on 31st March 2019. The number of existing sub-centers, this has increased by 591 PHCs by 540 and community health centers by 5 in 2019 over 2018. At all India level, there is a shortfall of 7,054 sub-centers, 12,004 primary health centers and 326 community health centers in tribal areas as on 31st March 2019 as compared to the requirement. Further, there is a huge shortfall in number of sub-centers in Madhya Pradesh, Rajasthan and Karnataka. There is a shortfall of 463 primary health centers in Madhya Pradesh, followed by 251 in Rajasthan and 247 in Jharkhand. In case of community health centers, Madhya Pradesh shows maximum shortfall, followed by Rajasthan and Maharashtra. At all India level, 10.33% of the sanctioned posts of health worker, that is a female auxiliary nurse midwife at the centers in tribal areas, are vacant as on 31/3/2019. There is a shortfall of 666 health worker ANMs in Gujarat, followed by Tripura and Karnataka. There is a shortfall of 230 health worker female ANMs in West Bengal, followed by Andhra Pradesh and Telangana. Shortfall of doctors at PHCs is highest in tribal areas of Chhattisgarh, followed by Odisha and Madhya Pradesh. Further, 18.8% of the sanctioned posts of nursing staff at PHCs and CHCs and 27.2% of the sanctioned skilled health personnel include doctor, ANM, nurse, LHV, midwife, 32 posts of doctors at PHCs in tribal areas are vacant as on 31/3/2019. The highest shortfall of 177 nursing staff at PHCs in Maharashtra, followed by Madhya Pradesh and Jharkhand. There is also highest shortfall of 326 nursing staff at CHCs in Odisha, followed by Jharkhand and Maharashtra. Now let us look at the state of health and healthcare in tribal areas. The tribal people in India form a heterogeneous group with a huge diversity. Yet the one commonality among tribal communities in India is that they have poorer health indicators, greater burden of morbidity and mortality, and very limited access to healthcare service. Now let's see what are the poorer health indicators. Firstly, talking about life expectancy. The estimates published in the Lancet 2016 show that life expectancy at birth for scheduled tribe population in India is 63 years as against 67 years for the general population. This life expectancy for tribal people is likely to be an overestimate because child deaths are underreported amongst tribals more often than in general population. Second health indicator is reproductive, maternal, newborn, child health and adolescence. The maternal health, there are no recent estimates for maternal mortality among the tribal women are available. Alarmingly, almost 50% adolescent scheduled tribe girls between the ages of 15 and 19 years are underweight or have a BMI of less than 18.5. NFHS shows that 65% tribal women in the 15 to 49 years age group suffer from anemia as against 46.9% other compared to non-SC/ST women. 27% tribal women still deliver at home. The coverage of postnatal care still remains poor. Now talking about the child mortality, infant mortality rate in India was highest in the world among the indigenous populations. However, the time trend analysis shows that the tribal IMR over the period of 26 years has halved, reduced from 90 to 44. This is certainly a major improvement. Next, coming to the communicable disease. The tribal population bears a disproportionate burden of communicable disease. It includes malaria, tuberculosis, skin infections, sexually transmitted disease, HIV, typhoid, cholera, diarrheal disease, hepatitis and viral fevers. Then talking about nutrition, the daily nutrient intake on an average intake of cereals and millets, this is decreased by about 50 gram per day between the second and third surveys in tribal areas. The average daily intake of proteins decreased by about 3 gram per day. The average intake of energy decreased by about 150% kilocalorie per day. To conclude, we can say that the tribal population in the country faces a triple burden of disease. While malnutrition and communicable diseases like malaria and tuberculosis continue to be rampant, rapid urbanization, environmental distress and changing lifestyles has resulted in a rise in the prevalence of non-communicable disease like cancer, hypertension and diabetes. To add to this, there is also burden of mental illnesses, especially the addiction among tribals. Thus, overall tribals are facing serious problems of health and nutrition which needs to be addressed forthwith. So learners, hope to meet you in the next session. Thank you.